A patient comes in with severe burns covering their chest, their right arm, and the front of both legs. How much of their body is burned? You need that number fast because it tells you how much fluid to give. And if you get the fluid wrong, the kidneys shut down. Now, here's how to calculate it, how to treat it, and the flip at 24 hours that catches every student off guard. Now, how to measure a burn. The rule of nines. Think of the body as divided into sections. Each section is worth 9% or a multiple of 9. The head and the neck are 9%. Each arm is 9%. The front of the torso is 18%. The back of the torso is 18%. The entire leg is 18%. The groin is 1%. And if you add all of that up, it gives you 100%. So the patient I described from the beginning, right? Chest is 18, right arm is 9, front of both legs is 9 each, 9 per leg. So 18 total. You add it up, 18 plus 9 plus 18 equals 45% of the body is burned. And here's the memory trick. 9 for the head, 9 for each arm, 18 front and back, 18 each leg, 1 inch in the groin area. A quick note, in children, the head is bigger proportionally. A child's head counts as 18% instead of 9. The legs are smaller at 14% each. The NCLEX may test that difference. Now, why do burns need so much fluid? Burns don't just damage the skin, they damage the blood vessels underneath. So in other words, the walls of those vessels become leaky. Fluid that's supposed to stay inside of the blood vessels starts pouring out into the surrounding tissues. Think of a garden hose with holes poked in it, right? The water leaks out before it reaches the end. That's what's happening inside the body. So fluid is leaking out of the bloodstream into the tissues. And the patient looks puffy and swollen on the outside. But on the inside, the blood vessels are running dry. Now, when the blood vessels lose too much fluid, the blood pressure will drop, right? The kidneys won't get enough blood flow. Without enough flow, the kidneys start shutting down. That's why burn patients need massive amounts of IV fluids in the first 24 hours. You're refilling the hose faster than it leaks, okay? Now, doctors use the Parkland formula to calculate how much fluid to give. It's typically 4 ml times the patient's weight in kilograms times the percentage of body burned. It gets split in half in the first 8 hours, the other half over the next 16 hours. You front load it because the leaking is worst early on. Here's an NCLEX tip. 3 things the NCLEX test about this formula. First, the fluid of choice is lactated ringers, not regular saline. Second, the clock starts from the time of the burn, not when the patient arrives at the hospital. If they were burned at noon and arrive at 2 p.m., you've already used up 2 of your first 8 hours. Third, you measure success by urine output. Target is 0.5 to 1 ml per kilogram per hour in adults. If urine drops below that, the patient needs more fluid. If it's above, you may be giving too much. You're adjusting the IV based on what comes, not just what goes in, right? So the flip at 24 hours, this is the part that catches everyone. For the first 24 hours, fluid is leaking out of the blood vessels into the tissues. You're pouring fluid in to keep up, okay? Then around 24 to 48 hours, the damaged vessels start healing. The leaking slows down, and all that fluid sitting in the tissue starts moving back into the bloodstream. Now, suddenly the blood vessels are full again. In fact, they may be too full. The heart now has to pump a much larger volume. If the heart can't keep up, the fluid backs up into the lungs. The patient develops crackles, shortness of breath, and rising blood pressure. Now, here's an NCLEX tip. If NCLEX describes a burn patient who was stable on day 1, but on day 2 has crackles and climbing blood pressure, they're testing whether you recognize that the fluid shifted back. The treatment is no longer more fluid. It's managing the overload. Possibly water pills, right? Diuretics, elevate the head of bed, watch for breathing problems. The game completely changes at 24 hours. The electrolyte flip, right? Now this is high yield. 2 electrolyte shifts within the fluid. Potassium goes up in the first 24 hours. The burn destroys the cells. When the cells break apart, they spill their contents into the blood. Cells are packed with potassium. Massive cell destruction means potassium floods the bloodstream. So high potassium puts the heart at risk. Sodium goes down in the first 24 hours. Sodium follows the fluid, right? That's leaking out of the vessels into the tissues. As fluid leaves, sodium goes with it. After 24 hours, when the fluid shifts back, they reverse. Potassium drops and sodium rises. Here's the memory trick. First 24, potassium up, sodium down. After 24, they flip. The electrolytes follow the fluid. When fluid leaves the vessels, potassium rushes in and sodium leaks out. When fluid returns, they swap. One more thing, always check the airway first. This is high yield. If the patient was burned in a closed space, like a building or a car, right, heat and smoke may have damaged the inside of their airway. So the warning signs are cinched hair inside their nose, right, the black suit around the mouth, or a hoarse or raspy voice, or a high-pitched sound when they breathe in. Here's another NCLEX tip. A swelling airway takes priority over everything else. Burns on the skin can wait, an airway that's closing cannot. If you see those warning signs, the patient may need a breathing tube placed before the swelling shuts the airway completely. Always assess the airway first in any burn patient. So remember, rule of nines tells you the size, Parkland tells you the fluid, urine output tells you if it's working. At 24 hours, the fluid shifts back and the game changes. Potassium is up, then down, sodium down, then up, and always check the airway first. Drop the burn percentage for the scenario in the comments. Both arms, the entire back, and the groin. Do the math. Watch it once to learn it, watch it twice to own it. I'll be right here when you come back. Think like a nurse, pass like a nurse. Happy studying.